Good morning, Salotine Edlaut. Say hi, say what's up with the Thailand and Ohio. I know last week no bakailt it's a little different. But good morning. Says Zibadan O'Sneel, the sea Willis John Vie Hushin into last tours in the Losh, Saskatchewan and Clearwater River Dene Nation band member his and Dunes in a treaty for territorials in Oaluntati Nadlisa. And doing Zinige, we've got no about guest one more time. NITHA was the Northern Intertribal Health Authority was in Noba. Sunsa TB presentation no Leanoba and Kondisia Base, questions to concerns no it's in it. Don't be shy to comment and we can ask. So I think most of it tot inailia, say denayas, but Tiffany, Adam, Chu, Leslie, Brooks, I'll be going over the presentation. So, yeah, say what's up. No go there with Ozzy. Let me know. Let me know. Do ja se til hadjurna jail they see no hanens and launt edzau. I don't know that Ozzy. And this weekend FSIN hockey tournament. Hell, I hope maybe we'll see everyone around there. So with that, I will bring him in. I will introduce Tiffany and Leslie to the show. Welcome. Good morning. How are you guys?
Good morning, Willis. I'm great. Tiffany looks great, so I think she's great too.
That's good. That's good. Well,
Morning,
Nezu, Nezu. Yeah. Thanks for doing this again one more time. TB tuberculosis. We've got the presentation here. We're gonna get started with. I'll just see you ladies to introduce yourselves, and we'll get going.
As Leslie said, my name is Tiffany Adam. We're calling in from Northern Intertribal Health, Treaty 6 territory, land of oh my goodness, Cree Métis people. I am. We're calling from the office today. So I'm one of the TB nurses that work within NITHA. There's a few of us here in our team. Last time we had met another member of our team, Erica Martin. There's a couple more, Barb George and Mary DeRocher, who aren't here right now, but we have Leslie here too. And like Leslie said, we're good friends here, and we can just have a discussion and go through the PowerPoint.
Right. So I'm Leslie. I'm one of the TB nurses here, and I've been working with NITHA TB program for a few years. I've been a nurse for a really, 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 really long time. So I do know a little bit about TB. We all know a little bit about TB because in this program, we would hope that we wouldn't even have to have presentations about TB. We would hope by now in 2022, we would be talking about it historically, but we're in the middle of outbreaks in quite a number of our communities. So we just want to get the message out, I guess, is basically why we appreciate being on Willis's program. And we also just want to try to decrease some of the stigma around TB by acknowledging what went on in the past and our hope that we can, shine some light on this and make things better and get rid of TB. So that's basically the goal of keeping everybody informed. Okay?
Yes, absolutely. Okay. Good morning, Sharona. We just seen that you had popped up and said good morning. So good morning to you guys over there. So tuberculosis, what should you know? We'll go through this, like Leslie said, and we'll go present the podcast. Goodness, this is kind of small print, eh?
Hold on. Yeah, for my old eyes. My gosh, I wouldn't be able to read any of that.
Mine are getting just as old, I think.
Sorry, we should talk about
I can make it the full screen there.
Like poster size. Thank you so much.
Thank you, Willis. Okay, so
yeah, so the history of TB is awful, and we're aware of that and respectful of the fact that that's what limits us in some of the communities, is having to speak about a part of history that is really awful for Indigenous populations. And so part of our discussion is going to surround the TB sanatoriums, residential school, intergenerational trauma, and for some people listening in, that can be triggering. So just want you to know that if this happens to you, please reach out to talk to others following this presentation. You can reach out to us as well. We're here in the office. So in 1867, TB or tuberculosis was the leading cause of death in Canada. So proof that TB was contagious led to organized efforts to isolate those infected in sanatorium, which was special hospitals where patients supposedly could get rest and fresh air and good diet. So the bottom line is this is not necessarily all true. I see a comment about the treatment for TB is awful, and you're absolutely right. It is awful, and it's long. It's very difficult to take those meds for a long time. But I think, to be honest about sanatoriums past, is that, yes, people were put in the sanatoriums, but initially, I don't think it was for the betterment of Indigenous populations. I think it was meant as part of a way to eliminate Indigenous people, really. So we have that history to contend with and to honor and answer questions about, because Indigenous children were knowingly infected with the TB germ to experiment on. And this is well documented in Canadian history. There's a book was written by Dr. Peter Bryce in regards to this situation. And the treatment that we used back in the 50s is still the same treatment we're using now. So the thing with that is we can talk a little bit more about the treatment, and people would think, wow, 2022, we should come up with better antibiotics. But the thing about TB is it's a very slow growing virus. I'm sorry, bacteria. I got COVID on the brain. So it's a very slow growing bacteria. So you really need medications or antibiotics that can cure this slow growing bacteria. And the TB treatment that we have now is, like I said, similar to what we had in the 50s. So we had traveling TB clinics back in Ontario that started back in 1923, and very soon they were used in every province of Canada.
So we can go to the next slide there, Willis. So history of TB and Indigenous peoples, as Leslie has mentioned, there is quite a dark history there for our people. Many of us may recall or heard stories from our parents or even our grandparents about, what had gone on, and it isn't easy to deal with, especially with everything else that our peoples have gone through with the residential school, and then how that trickled down with intergenerational traumas. It is still something that is scary to our people, and even for myself, I've got parents that were in the sanatorium for years. I myself was actually sent to Uranium City Hospital, where I had to be treated for TB without my parents there. So it is something in my past, and when I think about today, I think about how kids can stay home and remain home with their treatments, and if they're hospitalized, that we're in a different place where we can actually have our parents there with us if that was the way that it needed to go for their treatment plans. I'm grateful for the move in our healthcare system. We still have a long ways to go, I'm sure, but we can all work towards that together.
Ooh, that's a frightening view.
Yes, and then the next slide, I don't know what happened to our slide, but we're all up on this screen now.
Woo! We're rarely up on that screen. So here's an interesting comment about TB. So it's a little bit about the stigma around it. Is I was working in one of our other communities actually for World TB Day. I was in Pelican Narrows for World TB Day. So we had a bunch of informational sessions, and we went to a community hall, and we had kind of a nice turnout. Then I watched your presentation after.
Yeah.
I didn't know Tiffany had TB, and we're co-workers. So that just sort of speaks to sometimes people don't want to talk about their TB history. The pain is real. The fear of not knowing what's going on is real. So it's always really humbling when you hear stories like this and you think, we should have done better. We can do better. We need to do better. So while I was in Pelican and we were having this little presentation, we were kind of, some of the TB workers were a little disappointed because we didn't have a huge turnout. You know, there's other events that were going on and lots of people were coming in. But we counted throughout the day that we had 50 people come in. And I thought 50 is huge for people to actually want to come in and learn about TB and talk about TB. And a lot of people didn't want to talk openly about their TB. They approached me quietly at the end of the day, or if I was out doing something in the other area of the arena there, they'd come over to talk about their TB, their memories of TB, and saying, oh, you can share my story. I'm not comfortable to share it, but please tell them about my dad who had TB. Tell them about when I was 19 and my dad died from TB. And I thought, that's really quite remarkable that people are even, you know, just coming forward with those kinds of stories now. These are people at my age, you know, so it's interesting.
It's not easy to openly discuss because they're like, you know, the sanatoriums weren't designed to really care for the patients.
They said they were, but that was a lie. Like most things that had to do with the Indigenous population, really.
And, you know, like to think, if we think about our children today, I can't even imagine having a child sent off to a hospital. And, you know, like one of my kids, I couldn't imagine having that happen. But, you know, yet it happened to myself when I was a kid. And, you know, I've never really talked even openly to my parents, honestly.
When you think about it,
when I think about it, about, you know, when I was in the hospital, only because, I don't know, it's just, it happened, and what can we do, you know?
Well, and you don't ever want to, you don't want your parents to feel blame or
no,
shame.
Exactly.
Because there's enough of that around TB all the time.
Yeah, but the history is definitely there, and I'm grateful that we're not in those times and that we're trying as a team and as people, as healthcare providers to try to help support each other and find better ways of supporting the people in the communities, better ways of supporting each other as we deal with these issues that are in the communities as a team here, you know. So I really appreciate all this. So we can go to the next slide.
I think he's afraid to go to the next slide in case he's got those giant faces on his screen.
Okay, these are just photos of, you know, this was a Fort Qu'Appelle sanatorium, I believe. Yes, Fort Qu'Appelle TB sanatorium. So as you can see in that one room with the beds, they kind of did arresting and
they used to actually physically restrain children in the beds. What would have benefited them was probably to run around and have fresh air and play outside. But they weren't allowed to do that. They were strapped to those beds. Maybe they were wheeled into maybe that was a screened in area where that's the sunshine and fresh air that you got shining through, you know, dirty windows, I imagine. But it's not a proud history, but it's one that, you know, we need to learn about and we need to talk about and we need to acknowledge, because most of those kids, probably a great number of kids that died in residential school died from TB, just so that we're honest and true about that.
So yes, I remember, and I was raised in the territories, so as you might know, on Fort Smith is where I was actually raised, and I remember seeing the old St. Anne Hospital there, and that hospital had like sunrooms almost at the end of the end of the end of the hospital. And I remember telling my granny, like, I said, oh my goodness, I said, that looks pretty neat. I said, there's like sunroom, like, is that a visiting room? I thought maybe it was a visiting room. And she told me, she says, no, she says, people used to have to lay out there in beds. That was for TB patients. So that, you know, that makes sense. So even looking back at the old St. Anne's Hospital that they tore down over there, it was still right there.
Yeah.
But yes. Okay, so the next one. So TB. TB is an infectious but preventable and treatable disease caused by by Microbacterium tuberculosis. That's a mouthful at times. It most commonly affects the lungs. However, it can affect other parts of the body, including the brain, kidneys, and spine.
Right.
You know, we see meningitis, TB meningitis, you know, and
yes, we've seen a lot of what is called extrapulmonary. So extrapulmonary meaning it's left the lungs and it's gone to other parts of the body. So the longer you have the tuberculosis bacterium in your body, the more damage it can really do. So if we find it early, that's our greatest hope. That's why we're always looking for TB. We're always thinking TB. And especially in the age of COVID, we really want people to remember, like, a cough lasting longer than 2 weeks. Yes, it could be leftover COVID, but it also could be TB. And if we can find it while it's still in your lungs, your treatment is still going to be long, but not as long as if it's moved into your brain or into your spine. It can move into your eye. Yeah, wow, that was the most. And just because we're going to put it out there, most recently, there's people can have it in everywhere the lymph system goes in your body. It can carry the TB germ there. Testicular, yes. So, yeah. So it's just that it's not just in your lungs, but that's primarily the most common area.
Yeah.
So, and there's 2 types of TB, of course, latent, which is sleeping TB, and active TB.
Next slide, Willis.
Yeah. So how is it spread? Well, absolutely. The most common way to spread TB, of course, is if it's in your lungs, is to cough. And it's droplet. So you cough the germ, you sneeze the germ, you can sing the germ into the air. And you actually then, in order for me to get it, I have to inhale that bacteria into my lungs. So if it's normally you're going to get it in an environment where you're actually sharing airspace. So when I say sharing airspace, it's with a mask off. Maybe you're over playing cards with your friends, or you're at your home where you're not having to mask for COVID or anything like that. And maybe we're sitting around playing cards for 4 hours in the evening. So we're laughing, coughing, having a really good time. And nobody's really concerned about my cough because, everybody's coughing now that they've had COVID. Like, let's not worry about that. And so you cough the germ into the air. And I always use the description of it lives in the air. It lives up here. And it can live up there for, at least 4 hours. So when the TB germ drops down and lands on a table or on a glass, it's inactivated. You cannot pick up TB from a cup, from sharing a cigarette. If I was to lean over and kiss Tiffany, she's not going to get TB from me. Well, because I don't have TB, but it's not, you don't get it that way. Whereas with COVID, you could pick up a pen, a cup, anything, and then scratch your eye, get COVID. TB is not spread like that. I have to actually inhale it into my lungs.
Breathe it in.
Breathe it in. So
next slide. So latent TB, this is basically what we call the sleeping TB. People with latent TB have the bacteria in their body. It doesn't make them sick. It is not contagious, and there's no symptoms. Latent TB has the potential to become active when the immune system is weak, and latent TB can be treated with medication before it becomes active. Yeah. So this is where they offer that treatment. Once that person's diagnosed with latent TB, they offer what they call prophylactic treatment to prevent it from occurring, progressing to active TB.
Correct. So just think, if I'm not having a symptom, I can't spread TB. So if I can't cough, I'm not going to spread TB, right? If I get TB in my kidney, maybe it's left my lung and gone directly to my kidney without actually making me sick in my lungs. So these are all things that will be decided with the TB team, with the doctors and nurses. But latent TB, if we can treat that germ while it's still sleeping in your body, then we have an opportunity to prevent it from going active. Okay. Next slide. Are we talking too much?
I don't know. Are we talking too much, Willis? Do you have any questions? Are there any questions out there?
No, you're doing good. That's a very good presentation. Keep going.
Oh, thank you. So, fact, an estimated 2 billion people worldwide have TB infection. So, if you think latent TB infection, so if you think about it to your communities, think about 25% and where that can go within the communities. Just trying to bring it back home, 2 billion worldwide is 25%. But if we took that back home into a population of 1,000, that can easily be 250 people in your community. Yes. Just to kind of give you a perspective, not that there is that going on right now, just to help you visual or think about that in the community. So active TB is when the bacteria multiplies in the body and the immune system is unable to stop it at this point. The infectious person is now contagious and will show symptoms, and the person should seek immediate treatment.
Right. So
by that point too, they're usually getting pretty sick that they will and are presenting within the clinics and to their physicians.
So lots of people do present, sometimes present in their communities or want to present to the community, like they want to go in and see the nurse or the doctor, and they have some of these symptoms. And sometimes there are a few barriers because, you know, we have limited staff in some of the communities. Not every nurse that works or every doctor that works in a community has a clear understanding of TB. Because if you come from down south where we don't see active TB, we do see it in the immigrant population, but we don't see a lot of indigenous populations down south with TB. It's mostly a disease of the north, to be honest. So maybe you have to be a little bit persistent, and that's unfortunate, but you have to, if we could decrease the shame and blame around TB, maybe it's important to remind our healthcare professionals that, yeah, I understand there's a big TB outbreak going on. I'm here coughing, like I need to have some treatment, or you need to investigate this further. It's just something we would like people to talk about and not be ashamed about.
And unfortunately with COVID and everything like that, you know, it's really limited resources and tired everybody
it's
out.
Used every resource and it's tired everybody out. There's so much going on. So the symptoms of TB are, of course, you're coughing for longer than 2 to 3 weeks. Now that's with COVID. Some people have long COVID and they're still coughing from that. So the thing with TB is anything that makes you sick usually presents itself. So there would be other symptoms, night sweats, you're feeling tired and weak, and fevers and chills in the evening, weight loss, no appetite. Like, you will feel sick with TB. If it's early on and it's just a cough, we hope we can catch it then. You can cough up blood. People have chest pain. They have sometimes lower back pain. So, like I said, while a few of these symptoms are definitely similar to COVID, the difference with that is, you know, TB seems to really wreak more havoc on a person's body.
I keep reaching for the mouse as if I have control.
You have no control. We have no control
over his PowerPoint. So risk factors. One of the most common risk factor in our communities is overcrowded living conditions. Because with overcrowded living conditions, you can be exposed more to that TB germ if one person in the household is considered contagious and infectious. Exposure to an infected individual, diabetes, HIV, drug and alcohol abuse, use of steroids all lower the immune system. Cigarette smoking and marijuana smoking also damages the lungs. One of the things that I've kind of seen and witnessed, I guess, I don't know if there's with marijuana smoking.
Yes.
They kind of gather in crowds and groups, often enclosed, not well ventilated areas like the Brioks, they call it
smoke shacks.
Yes. Yeah. And so when they do that, like you've explained earlier, when that person is coughing, it lingers there, and then another person inhales that bacteria. So in traces, it's not uncommon to see that, and where it's coming.
Right. So a lot of young people will say, "Can I?" They actually ask these questions. Can I spread TB by sharing a cigarette or, you know, a joint? And I always say yes, because it's not the actual sharing. It's not that we're going to share the cigarette. It's the effect of marijuana, which makes you cough. So you're coughing, and I mean, if you've had a few joints, you're pretty relaxed, I would imagine. I wouldn't know this personally, but so you don't have masks on. You're not in a smoke shack wearing a mask, right? And you're coughing in the air, and you're coughing that germ. And the good news is we're probably going to spend a good amount of time together because we're friends or family. So, I mean, that's the biggest thing. We do see it in a lot of younger population where they do share a lot of airspace.
As opening windows, keeping those
Yeah,
ventilations
spring
open.
is coming. Maybe we can be outside. We can lessen our chances by just being able to crack open a window and a door. So when we talk about HIV, Hep C, those areas, like you have 100 times greater risk of getting TB when you have a hit to your immune system. So anytime your immune system takes a hit, which means you've got a disease like diabetes, which makes it a little bit more difficult for you to fight off colds and things like that. So you might have a 3% chance of, or a 3 times greater chance of getting TB if you have diabetes, but you also have a 3 times greater chance of getting diabetes if you're a smoker. And I think COVID, if you have COVID, that would increase your chances. So you have 3 times greater chance of if you have diabetes, and you have a 3 times greater chance if you have a cigarette or you smoker. So that's 6 times right there. So you're increasing your chance with any kind of situation that lowers your immune system. But like Tiffany pointed out, the greatest risk is our overcrowded housing situation. And if we had better housing and more housing, I think you would see so much less TB in the north. You would be amazed if we could just get more housing.
So about 5 to 10% of infected people who don't receive treatment for latent TB will develop active TB. So this is where we talked about the prevention, the prophylactic treatment. So if you've ever been told you have latent TB and they go in and they offer medications, often I hear, well, I'm not even sick. I don't even have the symptoms.
Right.
I don't want to take these meds that might make me feel crappy, and the resistance is there. It's felt. But this is what we're trying to do, is preventing it, because within that 2-year time frame, if they do become active now they're going to expose, once they become active, they're going to expose other people and more people, and maybe even reinfect other people who had TB before. So this is where we're always pushing for that latent treatment.
Right. And that's, I think you're right. That's the hardest thing to convince people, is to take treatment when they don't feel sick. Like, I mean, I honestly would have a hard time with that as well. I am a TB nurse, so now I understand it. And as I get older and maybe closer to retirement, and I maybe have latent TB germ, but maybe my diabetes is acting up and my immune system isn't as good, and maybe I'm developing a couple of symptoms, I might consider taking treatment, just for the fact that I wouldn't ever want to have to take active treatment. If I could go from taking treatment once a week, so there's treatment, latent treatment can be once a week treatment or twice a week, depending on how you tolerate one of the medications, for 3 months, as opposed to 5 times a week for 2 months, and then 3 times a week for another 6 to 9 months. Treating latent TB is another real effective way to try to get rid of the TB.
So diagnosing and screening. So we have the TST skin tests in the picture there. You can see, I don't know, I remember getting those bunny stamps and getting the bubble put under my skin. So that's basically one of them. That's a TST skin test. We plant them, we go back and we read them at least 48 hours after. And another way is chest x-ray, sputum sampling. In the slide it says spit. It's not really spit, it's the cough that's in the lungs. And
the deep down basis of the lungs, a deep hooked up bunch of phlegm.
We also have blood tests that they can do. This sputum sampling is that's another hard area I'm finding, to get the sampling back, and the amount, it says under about 10 mils. So when in those orange caps, and you see that line, then we are lining it, and it seems like quite a bit actually. So getting closer to that 10 mil mark is best, so that it is not rejected. And even with those tests, it's kind of tricky, as we've learned.
We're finding out. Yes. Like TB, that's the interesting thing about TB. It's sneaky. It changes. We interuse words, infectious and infected. And I mean, it can be really confusing. So like Tiffany mentioned that she has had TB in the past. So one of the things we couldn't do for her is do a skin test.
No.
because she's already been positive, so we would never want to give her the germ in her arm again because she's always going to be positive. Once you have TB germ in your body's always going to recognize that little bit of germ we put in your arm. So if Tiffany presented and she was a little bit symptomatic, the first thing I would want to do is I really, really want to get a sputum sample. And you're getting a sputum sample and you're spitting it into the cup. I've tried to quit using the word spit. I've tried to use sputum, but you are spitting it into a cup.
And if you're explaining it to the elders in Dene too, I'll say de course, like it's because it's right in the chest, and they'll understand what that means rather than
Right.
like there's the terminology too, so it's
important to understand that. And it's always easier sometimes to cough a specimen up in the morning when you've been laying down all night and all this sputum is sort of collected in your chest, and you get up and you can really, I'm going to use the word hork up a good loogie.
Yeah.
That's what we used to call it back in the day.
We call it de course. But anyway, so this is the most accurate method of diagnosing active TB. Say de course again.
De course.
Yeah, good job. So loogie. So who should be screened? Anyone who has recently been exposed to active TB, new immigrants, children less than 5 years old, adults older than 65, people with HIV, diabetes or kidneys, all those other risk factors, people living in communities with high rates of TB. This is pretty much our north. And one thing we don't have on here is healthcare providers too.
Yes.
Some what is it called? Occupational health and safety. They'll have policies and procedures in place where, as healthcare providers, that we would have to go and screen, like even if it's a annual x-ray, like chest x-ray, like for me, they're not going to do my test and I'm not symptomatic, so I can't give spit, but I can get a chest x-ray done. So that's one thing that's missing in there too. But that high rates of TB, like we've mentioned earlier, we do have 3 active current TB outbreaks in our communities. NITHA has 33, and that's a huge number.
It really is. And it's really disproportionately affecting children. So that's our greatest risk, because in 2022, we should not see children with TB. We would maybe expect it in people who are having a challenged lifestyle, where they're maybe homeless and battling addictions, and they're in circumstances beyond their control that would cause them to be living in those close confined quarters. But children in 2022, it's an outrage, really, and it shouldn't be happening. So we really need to do better, do more.
Droplets can last in the air for hours in the air, as Leslie mentioned.
So, there are risk factors, like everybody now wears a mask when they go, I mean, for transportation and things like that. So when we say TB droplets can last for hours in the air, they can. They can last for, like, the minimum amount of air exchange you'd need to be probably exposed for 4 hours, I would say. So, I mean, just imagine you've gone out to play cards, it's a nice summer night and you're out playing cards and with your friends having a good time, and you're coughing and laughing and singing. Those are all things that can propel, if somebody's infected and doesn't know, like, people don't do this knowingly. They don't know they have TB. A lot of people just think, oh, it's a smoker's cough. I had COVID, a month ago, and I'm still coughing from COVID. So.
And the exposure, I remember looking back previously, it was like 10 hours exposure over a 1 month period. So we're not saying you're going to go walk in and inhale it and just be infected with TB. There's a time frame there.
There's a time frame. And your health, your overall health. Like, if I'm out playing cards and having a good time, and
we're likely going to sit there for a while.
You're going to sit there. And not only that, but my immune system is healthy. I'm feeling good. So I get that TB germ in my body. So while 5% people might get active TB, 95% of people can put that germ to sleep in their body. So my immune system is good. I don't have diabetes. I don't smoke.
And that medication, they would bring it down to nothing. You're nothing.
Yeah.
So treatment requires months of antibiotics. It is important to complete treatment and prevent regrowth of bacteria. We talk about resistance. You might hear it even in the community with anything. If you go in for like a bladder infection or a lung infection or eye infection, your nurse practitioner or the doctor might be explaining to you, please, even once you feel better, you need to complete that medication because your body can become resistant. And once it becomes resistant, we have to change the medication. And if we can't do that in the world of having only the same medications for
50 to 60 years,
yes, then that's going to be a difficult situation to run into. So the importance of completing the treatment is key. Patients are often monitored by the nurses and to ensure that they're taking their medication. The one thing I'd like to mention here is TB workers are the ones who are really the superheroes here because they're right there in the community. They're from the community. They go to the homes. They're the ones who are giving the medications. They're the ones who really are reporting
Yes.
with the support of the nurses in the community and the support of us and the support of TB control in Saskatoon. So there's really quite a team that comes together for this, but like I cannot express the importance and the value of our TB workers in the
Absolutely.
community.
They really are the superheroes of this because they give the meds daily. They're the people in your community that are going to be the ones coming to your home to give you the medication so that you can stay home.
Yes.
So
Yeah.
we rely on them.
So help eliminate stigma. Share what you've learned today with your friends and family. We need to keep spreading the word of TB. I remember hearing back, like I've been nursing for 15 years now, and I started my career up in the territories, and I didn't even think it was anything of today's time. And I came back to Saskatchewan for 1 year, 11 years ago now.
That's how it happens.
So I remember hearing about one of my first cases in the community that I had just started, and I thought, wow, like we still have this here. And there was that big campaign, Stop TB.
Yes.
And then I worked up in Fond du Lac and that with I have to brag about my past friend Susan Henny, and she really was a good mentor, and she really was one that always TB, think TB, and all of us can continue to spread that word of trying to stop this because it's sad to think that people can get that sick and die today with something that we can easily prevent and treat.
Right.
So if you or somebody you know gets TB and we're doing investigations, please don't be afraid to list names because we're just trying to find where it might be so we can just stop this in the community. Right.
And remember, your nurses may not be familiar with TB. Like we say, COVID has really knocked the stuffing out of just about everybody. So sometimes there's nurses that are not familiar with TB because they've come from a different community. Some nurses, like anybody else, are a little bit apprehensive. So if you've had a cough, you can use the words, hey, I just watched those two great TB nurses on that Dene Yati podcast with Willis, and they told me I should come in to get tested for TB.
Yeah.
And
and here's just links of resources.
There's many resources out there, and the greatest resource is people in the community that experienced people that have experienced TB. So I just wish that we could open the doors and everybody talked comfortably about TB. But it doesn't always happen the way I want it or we want it.
We're not in control.
No, even though
nothing ever goes that way, does it?
No.
No. That was very good presentation. That is the end of it. But there's a lot of points you made. That I was just taking notes in the back about. One of the first things that I know Tiffany talked about this when it comes to overcrowded and housing, and a disease of the north. That's that was a very interesting statement to. And these are facts too, right? Why is it a disease of the north and and not spread anywhere else?
Well, what's interesting, Willis, to me is that
it is spread other places. It's just satellite.
Yeah, it's more satellite. But I mean, anytime you have overcrowding and that, like, the thing is, it's easy for me to say because I am, of the settler population, so I can say housing would be better. It's political to say that in some of these communities when the TB workers, we all know that, let's be realistic. housing from the federal government has been capped. Like there hasn't been a lot of new funding. We need better and new housing. And if we had that, and if we had doors and windows that were actually able to be opened, and people have better ventilation, like housing is a big one. So, I mean, and there's some words that we have used in the past when talking about TB that are really disrespectful and unkind, a disease of poverty. Those kinds of things need to stop. A friend of mine, and I can't say his name because I didn't get permission, but we were in the airport at Stony one time, and he approached me, and it's changed how I present TB in the world now, because we sometimes used to use that word preventable, curable, treatable. So what I've started to say is it's manageable, because it's preventable if everybody's on a level playing field, if we all have the same resources, if we all have housing, if we all have secure food, if we all have good water, then it's preventable. It's manageable when you're not having those same resources. Curable, treatable, absolutely, those things will always stay, but I won't use the word preventable until we're all on a level playing field, and I don't know when that will be.
That's very good.
Yeah, that's not mine. I have to say, it was a friend of mine in the airport who, as a young man, had TB, and he said you need to quit using that word because it sets us up to make people feel a little bit ashamed of themselves, and it's no one's fault.
And you're right. Like when we're in the communities, even like accessibility to resources, and services. If I was to do a sputum test, a sputum sample on somebody, let's just say at the furthest point, Fond du Lac, that sputum gets collected there. It then has to wait for when it can be sent out, sent to the health authority, who then has to distribute and go through there, because they go blood samples, sputum samples. These things kind of get separated there. Then they have to wait for that plane to go down, get sent down to wherever it's going to end up in Saskatchewan. Then after that, when they finally get that diagnosis, they go back to the community. We got the diagnosis. Now we have to wait for the medications to be sent up. So
if you're in PA and you've got a cough, you're going to go across the street with your sputum sample and deliver it directly to the hospital.
Yeah.
There's TB prevention and control down the hill who's going to get your meds, and you could probably start meds. I mean, TB prevention and control does an excellent job, and they will fly meds up. They drive them up.
But even that, they'll do that. It takes time. Like we have whether the flights are canceled, and whether we're all dependent on the weather, especially in these fly-in communities. And
absolutely.
There's many barriers for us, that's for sure.
How long is that wait in between, getting the sample? Is it a week or two, or I know the challenges obviously with flying communities, but how long?
Depend.
It really does depend on.
So the first test is a PCR test, which was, people will be familiar with that because they had a PCR test with COVID. So there is a separate and special cartridge that can be used for the TB germ, and we could use the same machines. Those machines were actually, before COVID hit, they were placed in Stony and in Pelican, prior to that, just to test for TB. But interestingly, this is just something I can talk about because I've got nothing to lose here. So we couldn't get everybody to agree that nurses and LPNs could do the testing, right? It had to be specialized treatment. So there was so much political drama around who can do testing for TB on a PCR or on a GeneX machine. Well, lo and behold, COVID presents its ugly self, and everybody, Joe Blow off the street, can come in and we can train him to test for COVID. So now we're back to the fact that we can get testing for PCR. The PCR test done in Stony Hospital has a PCR machine. You do need to be trained, but we can find out within hours whether you have the germ in your lung. So, I mean,
if they have the PCR.
If they have the PCR machine. So, I mean, it can go there, and then we will know, and they will say you're PCR positive, which means you have the germ in your lung. It doesn't tell us if the germ is active or, sleeping. There has to be more tests. So that's one of the first tests. And then the rest of the specimens for sputum need to be collected because you need to find out if it's complicated. It's smear positive, smear negative. So it tells us how infectious you are. And so that will determine how long you have to isolate. So if you're smear negative, if you're smear positive, that's sort of what sets your isolation period. So it's complicated, and that's something that we explain to clients, and it's complicated and sometimes confusing for us. So it's complicated and
Yes.
confusing for clients as well. But we
Yeah.
have a wonderful team at TB Control. Like, we work collaboratively
Yes.
with them. We have wonderful doctors there, specialists, pediatricians,
Mhm.
really dedicated nurses and doctors at TB prevention and control in Saskatoon. So there's really a huge, I shouldn't say huge, because I mean, there's
We
a
have-
small group of us who are really dedicated to TB, and they're
Mhm.
wonderful. They're completely accessible. They help with education.
The supports.
TB's their baby, so to speak. So they know a lot. They're always accessible to us when we're working in the
Mhm.
community.
Absolutely.
They help us train TB workers in the community. Like, there's a really dedicated group of people out there that want to make a difference. But we're dealing with that ugly past.
Yeah.
It
And
it really sounds complicated for sure. I mean,
It is.
it's
You're right.
the political. You can't leave because of you can't leave that out because you're the ones going up there. You see the challenges, or even you got to accommodate each individual with certain treatment, I guess, when it comes to living and all that. Excuse my language, all that stuff. But and
Mhm.
it's very tough, I guess, to have to go and through that. But for the future, I mean, how do you introduce that with someone new? I know you mentioned you are of a settler population. For someone coming from the south to come work in the north, how do you help them transition into understanding that, okay, this is this. You don't want, I know as people, we want to help and fix everything right away, but that's not always the case here. It seems like bacteria of the past is still making its way, but so is the effects of colonization as well too, because
Mhm.
as you talked about in
Huge.
your presentation.
cultural
Oh.
competencies.
You're so right about that, Willis. Really and truly, I think what used to happen, and I can refer to the old days because I remember the old days, as a new nurse going into a community, a part of my orientation was to understand and learn, to honestly, to become culturally aware, like to make sure that I was understanding the community that I was going to, right? And with that, you have to understand, what are some of their risk factors. So maybe they have a lot of people with diabetes, or maybe it's a TB high incidence community. Those are things that need to be taught to new nurses. And to be honest, I mean, people can teach us, but wouldn't it be nice if part of the reconciliation portion of this was, if we were new into a community, that we made an effort to understand and learn a little bit, about what is actually going on in those communities. That's how we get to a better understanding.
Yes. And I think just being out there and engaging with the people and in the communities, it goes a long way. I know having tea with the granny has always been my favorite part of my job. And just really being out there. So that's huge.
It's a huge part
Even
of
if you're from the area, sometimes you don't, each community differs
so different.
from community to community. So it's huge part is engaging with the people.
I know, like, the stigma thing too, like, we shouldn't be talking about TB, and it just, as a Dene person too, I've been raised in that, and I know that something, when Tiffany approached me about this topic, I'm like, oh man, this is very strange, to deal with. But the stigma around communities, I mean, when dealing with TB, it just, to me, you're dealing with so much more than TB, because there's a mental health. There's someone that wants to take the meds for 9 months. Well, when I was using and substances, like I was, whenever I never finished my meds. I want to go out. If it's spring, I want to go out. Well, I want to do it, and now I'm jeopardizing my health, and I probably got to start over. There's so many challenges to this that, man, I mean, for you guys to keep walking into this and continue on, I mean, for me, it would seem like you know, maybe walking into a wall, but for you guys to keep doing it, it's good for you to keep the activism, I guess, going. It's just it's unbelievable to me the presentation you made and the things that I'm gathering as I go. So
And the thing is, a community education engagement. The more you give people, the more education you give to people about their health, the more engaged they will be, because health is only one part of healing, and so we need that investment and buy-in from the clients too. So if they are aware, me and my naive mind sometimes thinks that if you just give them all the information that you possibly can and continue to educate them, you give them that power. So it's about giving the power back to the people, and the more they know, the more they'll want to do. A person with diabetes, even if you teach them about how they can manage their diagnosis, they might feel empowered and engage in their own health care. So it's about, I like the education part.
Mhm.
Yeah.
Very good, very good, and it's doing good stuff. It's I mean, I keep going back to political ways, but I'm gonna try to leave that out because it's very tough thing to deal
It
with.
is very.
If there's anything else you would like to add, to this presentation here this morning, I'll leave it up to you, ladies, and we'll finish her off.
I just want to say thank you again, Willis. I'm very proud of the person you are, what you do, how you're continuing to keep the language and the culture alive. Just just the person that you are with your family and in the community. Way to go.
Merci.
Yeah.
Mm-hmm.
Thanks for inviting me. Well,
Yeah.
thank you, Tiffany. Thank you, Willis, for giving me this opportunity
Mhm.
and letting me speak English through the whole thing. And I apologize for that. I should know a
Yeah,
little
yeah,
bit of Dene. I
you
said
know
a
how to,
couple of
you
words.
said dekot, so.
Dekot. Yeah,
Yeah.
I don't ever like to butcher somebody's language, but I have done it for years. So yeah,
No,
I'm just I'm really excited that we have this opportunity
Mhm.
because, while March 24th is World TB Day,
Mhm.
every day is
Mhm.
TB Day for us.
Mhm.
And we really would
Yeah.
like to get to a point where, we don't have to, be beating our heads against those
Mhm.
walls. And people
Yeah.
there's so much education. People in the communities, there's people that
Mhm.
know so much about TB, community members.
They know more.
They know
some
more.
of them know more
It's-
than
Well, way more than us.
yes, because they've experienced it and they've gone through it. And
So the knowledge is there. It's just the shame and the trauma that goes with a disease like
Yeah.
this. So it's just, sometimes when you go into a community, I think we underestimate ourselves because we have a job to do.
Mhm.
We underestimate how much of an impact getting a diagnosis of TB is.
Mhm.
It's no different than finding out, because we're nurses sometimes,
Mhm.
you have a hard time understanding somebody gets diagnosed with diabetes. Well, don't worry about that. Like, here's the stuff we
Yeah.
can do. Just change your entire lifestyle,
Mhm.
lose a bunch of weight, take all these pills. You're going to feel so much better. Just not even realizing that this is a devastating diagnosis, as is TB, because of all the stigma,
Yeah.
disease of poverty, only poor people get it, all these kinds of things. That's not true. Like,
Yeah.
so we have to change our perspective as nurses as well, recognizing that this is years and years, like you said, of colonization and the mistreatment of indigenous populations and the lies perpetrated, and now not being able to in some of these communities even speak about, the inequities, the fact that there's no housing and food is so super expensive.
Yes.
Water's a challenge. So these are real things. So
Eat healthy in the north.
Eat healthy in the north, yes.
Yeah, the social issues are very real, and they come up. It's just ladies do a great job of just getting this out there. It's a lot of hard work, so keep on keeping on. Must see Cho.
Must see. Let everybody spread the word now.
Yeah, not the TB, the word.
The word of TB.
Alrighty, must see Cho. You have a good day.
Yeah, you too.
Thanks so much.
Alrighty, salot in a kuyi Leslie Brooks, Tiffany Adam adilat TB boss and Ohalyang theater. It's Bonnery yalant edlu TB gan yatia. You know, it's just I know the first time Tiffany bahalya iltiu dured you know so question I got tested for it and it's like there wasn't it and it's one on Easter. It's just you know, very challengingness than our simbo ba konti sia. So don't the symptoms no it's in a 2 weeks had in kodu to dal ad in kodu net in nadalu and tether nega tuna yere konti sia. You know, Arun Johnson, don't be shy, don't be afraid to go get tested. You know, a sile yade henny ladder. Another do tialia because you know so no was canu dan agode I baba adoil nide kontunezo. So with that doing zenege masi chona her sim salot in a tegol and obaral yanle ya sa edzalanta tsilana hujja hel so ya the another day atladene altilosa utadil inatlilosa masi cho si willa janvie hushe in Taylor's tours in La Loche, Saskatchewan, Clearwater River, Dene Nation band member the Heslio and Dunes Treaty 4 territories in Oel Huntati da Masicho.